And it's my great pleasure and privilege to have two of the giants in their own domain, Professor Thanvil, who does not require any kind of introduction to both nationally and internationally. So thank you very much, sir, for accepting to be the moderator for today's very important session. Thank you so much, Professor Thanvil. And we have another giant. I'm extremely thankful to Professor Sunil Thanvil. I think Myanmar will be immensely benefited with your clinical experience. As I was going through, you've done more than 40,000 procedures. It is mind-boggling. I think it's a great number. We cannot imagine in our dream here. So I think we are eagerly looking forward for your presentation, sir. It's a wonderful topic, for today's session. So I have a very small presentation to share. So welcome you all. Can you see my slide? Yeah.
Yes, sir.
Yeah. Welcome you all for this wonderful session and Zydus dedicated to life, as we say. Our vision, be a global life science company transforming lives through path-breaking discoveries. And our mission is to unlock new possibilities in life sciences through quality healthcare solutions that impact life. And our purpose is to empower people with the freedom to live healthier and more fulfilled life. I think it again, we are demonstrating the purpose by organizing this continuous medical education on insights into statin therapy. And this is a series of topic we are going to discuss under this topic. And most of you know Zydus has been indulging actively in supporting the continuous medical education for different therapy area. The purpose is, as you know, to continuous learning, continuous updation, so that end of the day, our patient is immensely benefited for the treatment outcome. So once again, I welcome the chair for today's session, Professor Thanvil, and our speaker for today's session, Professor Sunil Thanvil. And most of you know that, we have Alidac. Hello. Hello.
We can hear you.
You can hear, because there's a power cut. Maybe I change my service to portable. So we have our factory here about Alidac Healthcare Myanmar Limited. This is a pride of Myanmar, I would say. And it's a state-of-the-art manufacturing facility with the WHO GMP to produce high quality and affordable medicines in Myanmar. And it is very apt, Alidac Healthcare is coming into the savior for Zydus Myanmar, I would say, with the current challenges. Like most of us know, the import license issues, where the drugs would become scarce to be available in Myanmar. We are happy to inform all the doctors here that we will put all our efforts to make sure that our products will be available continuously. And also, I'm happy to inform you that there are price escalation due to foreign exchange escalation, and we are trying to control the price. We have not increased our price yet. Sej, could you put on mute? Others So Zydus' philosophy of quality management, as all of you know that we give utmost care in whatever we produce, and we adhere to the one quality policy worldwide. So even if the plant is located in Myanmar, but the quality policy is global. So every pill which is produced in Alidac will be of highest standard, which we can assure you at every point of time. And our range of products is the need of the hour. Most of the essential drugs, we produce here, starting from Amlodac, Atorva, Big Sense, Catanol, Citigo, and soon Dapagliflozin, and Xyrova, Nucoxia, Chino, etc. Most of the essential drugs are being produced. And as I said, current challenges is the import license issue. And Alidac, we will try our level best to make these products continuously available to our population of Myanmar. So thank you very much. And I hand over the session to Professor Tint.
Thank you. Thank you, Mr. Ram. I hope everybody hear me. You hear me?
Yes, sir. Yes, sir.
Well, good afternoon, everybody. I'm Dr. Thanvil. I'm a endocrinologist, diabetologist, and I'm the president of Myanmar Diabetes Association. And it is my honor to be a moderator for today's academic section, which is going to focus on acute coronary syndrome in patients without standard modifiable risk factors. And in fact, acute coronary syndrome and coronary artery disease are quite common. It is very common in our public, not only in the general public, it is more so in our diabetic patient. As you all know, diabetic patient, we have 2 to 3 times higher prevalence of higher incidence of coronary artery diseases. So acute coronary syndrome are quite common in our daily practice. And we used to hold symposium and CME program very frequently on coronary syndrome and the coronary artery diseases quite frequently. And most of the time we talk about modifiable risk factors, how to modify the risk factor, how to prevent it, coronary artery disease from the primary point of view, from the primary prevention, secondary prevention, etc. We rarely talk about non-modifiable risk factors. And as a matter of fact, we, as a non-cardiologist, have a little knowledge on the subject. Today, we are privileged to have an expert on the topic, well-known, renowned cardiologist, Dr. Sunil Thanvil, who will be talking about acute coronary syndrome in patients without standard modifiable risk factors. Actually, the topic is very relevant to our daily practice, as well as it is very interesting. And I have a great pleasure, before we start to the CME program, I have a great pleasure to introduce Professor Sunil Thanvil to the audience. Professor Sunil Thanvil is a senior consultant and head of the cardiology department of Zydus Hospital, Ahmedabad, India. And he also holds the status of Professor of Cardiology and head of the department of BM Patel Cardiac Center from South India. Professor Sunil is the principal investigators and co-investigators for several cardiology trials, including Balance, Hope Tree, Cure ACS, Trilogy ACS, School India, etc. And he is a very prominent and very successful cardiologist, and naturally he holds several, he's a winner of several awards, namely UN Meta Gold Medal of Cardiology 2002, Dada Nathambi Natubai Patel Gold Medal in Cardiology 2002, and awarded, is also awarded Glory of Gujarat for medical excellence by Honorary Governor of the Gujarat 2015. And he also won the award of Best Moderator Poster Award at the TCTAP Seoul in 2016. And he has great experience. He has a very extensive experience in cardiology, and he has performed more than 15,000 procedures as regard to cardiology. And he has published over 75 peer review papers if I have to read all the biography, it would take I just summarized, so just to introduce Professor Sunil to the audience. So Professor Sunil will be talking about acute coronary syndrome in patients without standard modifiable risk factors. So Professor Sunil, the floor is now yours.
Thank you, Professor Thanvil, for a very kind and extensive introduction. I thank Zydus Pharmaceuticals to provide us a platform to connect with Myanmar. And as Professor Thanvil very correctly said, it's a very current and a very contemporary topic that we'll be discussing today. We all know that coronary disease and acute coronary syndromes have a set of risk factors through which we try to risk stratify the patients, through which we try to plan all the preventive strategies, through which we try to plan the therapeutic strategies for patients who present to us with acute coronary syndromes. But what I'll be touching upon today is ACS in patients without standard modified risk factors, as they call in short form as SMRFs. So what is the presentation in these patients? What are the outcomes, and what should be the way forward? So in my today's talk, I'll be talking about what are the standard modifiable risk factors like diabetes, hypertension, as central elements of ACS risk mitigation. I should also be talking about the ACS incidence in patients without these SMRFs, the clinical characteristics of STEMI patients without SMRFs, prognostic outcomes in patients, and managing high-risk SMRF patients, how we should move forward. So when we talk about contemporary treatment of ACS, it relies heavily on treatment of standard modifiable risk factors. So whenever a patient comes to us in ER, the first thing that we try to do is we try to get a history of what standard risk factors a patient could be having. For example, whether he's a diabetic, is he a hypertensive, is he dyslipidemic, is he a smoker, alcoholic, does he have any other risk factors like family history of premature CAD, whether he's on medications like steroids. So these are all standard risk factors that could probably explain the event which the patient has actually come to us. There is also a lot of data to say that addressing these risk factors leads to substantial improvement in the overall mortality of these patients. The Finnish data, the FINRIS data for over 40 years showed that when you targeted smoking, when you targeted systolic blood pressures, when you targeted cholesterol, and when you target all these factors together, there was a significant reduction in the overall CSD mortality across the age group and across the overall population. So the point is that ever since CAD and ACS have started presenting themselves, we have been looking into a lot of risk factors to try to understand why it is happening and what can be done to prevent them. We also know from data that an intensive SMRF control will lead to more than 50% reduction in primary sorry. And what's also important to understand from this slide is that when you look at conventional therapy and when you look at intensive therapy, you can see that the endpoint is definitely a much less when the patients on intensive therapy as compared to patients on conventional therapy alone. Now, what would that mean? Intensive therapy would mean that we're looking at risk factor control across the spectrum in a very tight fashion. Systolic blood pressure less than 130, triglycerides less than 150, cholesterol, over total cholesterol less than 175, LDL cholesterol less than 70, HbA1c less than 6.5. So this is what we're actually looking at when we talk about intensive SMRF control. And definitely, we have found a lot of benefits by doing this intensive control. Next slide. There is a part of the regular COD risk assessment. We know that the framing of risk scoring, the European Society risk scoring, whatever risk score you take, they always involve the standard risk factors that are there: smoking, age, gender, diabetes, dyslipidemia, hypertension, so on and so forth. Next. And also the standard ACC-CSCD risk assessment also talks about similar risk factors. They talk about the blood pressure, the HDL, the total cholesterol, the LDL, history of diabetes, smoker, on statin, on therapy, on aspirin, so on and so forth. So SMERFs actually are a very integral part of both diagnosing and managing ACS and CADs in general. But look at the international guidance again. There are a lot of SMERFs that are there, and they always talk about the need for reduction in the risk factors to reduce the target damage and to improve the outcome. So they talk about quitting smoking, lifestyle optimization, blood pressure reduction, LDL reduction, A1C reduction, initiation of SGLT inhibitor or GLP now they've been included in patients, especially when you're looking at a patient with established CVD. Antiplatelet therapies are a must now, and along with therapies like lifestyle modification, improvement in psychosocial factors, antithrombotic therapy, disease-specific interventions, we are also talking about risk factor treatment and modification to reduce the future outcomes and to improve the prognosis in this group of patients. Next. We also know that the primary and secondary preventive programs that target SMERFs lead to significant reduction in morbidity and mortality in patients presented to us with coronary disease. Yet, acute coronary syndrome, STEM in particular, remains a leading cause of CV mortality. We know a lot of patients coming to us, young patients, no history of diabetes, hypertension, not too much of smoking history. Still, they land up with an acute STEMI, and we are actually left wondering what could be the underlying reason. The data says that nearly 25 to 27% of patients actually don't have any standard risk factors. And this is a paper that was published in 2017, European Journal of Preventive Cardiology, where they showed that the proportion of STEMI patients with STEMI poorly explained SMERF is high and is significantly increasing. Younger population, less amount of risk factors, and less amount of traditional risk factors, so as to say, and poor understanding of why the disease is happening. The incidence of STEMI in SMERF patients is continuously rising, and which was earlier 14%, has now gone up to about 23% of total ACS presenting to various hospitals, as was published in this study, JAC 2019. I'm sorry, excuse my cough. And they said that 18% similar rates of SMERF patients were reported for non-STEMI as well as STEMI. And the rate of ACS in SMERF patients are increasing, and absence of SMERFs is not uncommon, whether it is Europe, whether it's US, and whether it's this part of the world, the Southeast Asia, South Asia, but the number of patients without standard risk factors now going up. Again, if you look at the data from Asia, you can see that the graph is continuously increasing, and nearly 8.6% of patients had no SMERFs in this data, which was published in the Frontiers of Cardiovascular Medicine. And it showed that across various time-level age groups, the numbers are going up. Next. Next. This is a cross-section of various studies, infused CRISPs, where they showed that the significant reduction, a significant number of patients was SMERFless. If you look at the infused MI, 23% of patients. If you look at CRISPs, 19.5. The MI Hearty, it was 9%. And if you look at IDA, it was 11.3. Emerald, it was 22.7. So significant number of patients actually did not have the standard risk factors that could contribute or that could explain the particular ACS the patient was having. And if you translate these numbers with global CAG mortality, if you look at oral ACS, nearly 7 million adults die because of ACS globally every year. And if you account for SMERF patient, that is still 1.75 million. So a huge number of patients wherein there's absence of standard risk factors, and yet the patient presented to us with acute coronary syndrome. So what could they be? So a very common question, young males coming to us, females, where we don't see the standard risk factors with them, they come to the acute MIs, and a very common question, why me, doc? Why? There's no hypertension, no diabetes, I don't smoke, no other risk factors, then why me? The problem is that in women, the prognosis is worse, and the absence of risk factors are much more higher. Absence of risk factors does not preclude atherosclerotic plaque development and progression. That is a fact. And if you look at the data, the various theories that are postulated are, of course, inflammation. We know that any acute event needs a trigger, and inflammation since a very long time has been postulated to be a very significant trigger for acute coronary events. In fact, the HSCRP levels tend to tell us that the patient could get higher risk for an event as compared to a patient who has a normal HSCRP level. Air pollution now is a well-known risk factor which is coming into play. A lot of papers from Europe, from US, from Asia to tell us that patients who are exposed to a very poor air quality have higher event rates as compared to patients who live in a better air quality places. Genetic loci definitely makes a difference. We know that there are populations, we know that there are people wherein they have a very strong family history of premature CAD, and therein the patient may not actually have standard risk factors as such. And of course, the presence of subclinical risk factors that could account for this ACS and the plaque development and progression. Next. A very prominent study, the Sweetheart study, which talked about the mortality in STEMI patients without standard modifiable risk factors, published in Lancet 2021. They showed, next slide. It was a study which looked at the clinical characteristics and outcomes of adult patients with and without SMUFs, examined overall and by gender. Patients with a known history of CAD were excluded. Primary outcome was all-cause mortality at 30 days after STEMI presentation, and included cardiovascular mortality, heart failure, myocardial infarction 30 days, and they were examined at discharge and the end of 20-year follow-up. So it is a long study, and what they found out that contributing risk factors in patients with SMUFs, it was of course diabetes, smoking, dyslipidemia, and hypertension accounted for a large population of patients with acute MIs. But there was a 15% population which had no significant risk factor profiling. What is important is that obesity was not supposed to be a contributing risk factor for STEMI in patients without SMUFs. So probably that could also account for one of the risk factors that we're looking at. If you look at the character of these patients without SMUFs had lower systolic BP and lower heart rate, which means they were sicker, more likely to present with cardiac arrest than patients with SMUFs. Time difference of symptom onset to percutaneous PCI was shorter by 12 minutes in patients without SMUFs. Lower EF and higher drop levels were noted. Lower likelihood of multivessel CAD. Cartilage and LAD was more common as compared to patients with SMUFs. Less likelihood to receive statins, ACE inhibitors, ARB or beta blockers. This disparity was more pronounced for women. Now, these were all data which was picked up by Sweetheart when the study was conducted across Europe, and they followed over a period of 12 years. Next slide. We look at the clinical outcomes. In hospital mortality, cardiogenic shock, MACE, all-cause mortality, they were always higher when the patients had without SMUFs as compared to patients with at least one SMUF. Patients without SMUF had a relative 47% higher. Excuse me. Higher all-cause mortality 30 days post-MI as compared to patients with SMUFs, and increases for all-cause mortality persisted in the long term. Next slide. Excuse my cough, actually, I'm having a bad throat today. Next slide. So it is expected that the rates of mortality can be attenuated with the use of guideline-directed medical therapy. So what we're looking at now is that in patients of ACS without SMUF, because the STEMI patients, the door-to-balloon time was much higher in patients who had with SMUFs as compared to patients without SMUFs. Those present with single vessel disease were again higher in patients with SMUF as compared to patients without SMUF. LAD infarction was again more common, and in patients pre-PCI time flow grade 0 to 1 was again worse in patients with SMUF. Next. So it said that higher proportion of SMUF patients in anterior MI as compared to non-anterior MI. While the age group did not differ, SMUF patients were more likely to be male. LAD was a more likely culprit lesion in SMUF patients, and SMUF patients had a poor coronary flow as compared to patients with SMUF, despite adjustment for age, gender, and LAD or non-LAD lesions. Next slide. If you look at the imaging characteristics again, we'll find that there's nothing really significant to talk about. But the overall infarct size, infarct mass, they were much worse in patients who are smurfless. Next. So smurfless status was not an independent predictor of infarct size or LV ejection fraction or the overall multiverse involvement, but there was a definite difference when you look at the data of the patient with SMRF and without SMRF. Clinical outcome wise, if you look at 30 days, death, heart failure, hospitalization, MI, again, you can see there's no significant clinical difference. However, the trend towards death was actually much more in patients, those who did not have any standard risk factor, whether it was at during hospitalization or whether it was at 1 year. Next slide. If you look at the cardiac MR of SPECT less than 1 month after MI, you can see in SMRF patients versus more than one SMRF patients, it was actually worse. You can see 72% involvement, a total of infarct mass of 32.2, and EF over 48.8 as compared to 49.7, and better outcomes in patients who had at least one risk factor, which was standard. Next. Next. So what is also important to understand is that despite poorer pre-PCI TIMI flow, there were no significant differences in infarct size or 30-day and 1 year mortality. Why? Actually, the overall rate of mortality was low, maybe because of rapid performance of primary PCI, and maybe because of aggressive implementation of adjunctive pharmacotherapy. Also, smurfless patients in the study had a healthier macrovascular state at baseline because they were not diabetic, they're not hypertensive, they're not smokers, so they probably the microvascular was much more healthy as compared to patients with SMRFs. When you look at the non-STEMI population, the UK MINAP study, which looked at a large number of non-STEMI patients, they found that nearly 23% of these patients did not have any standard risk factors. Next. And if you look at the clinical characteristics, they're almost similar, whether the patients had SMRF or not. But the prescriptions of the medications like statins and RAS was actually more common in patients with SMRF than those without SMRFs. More than 1 in 5 patients did not actually have any standard risk factors, as it was found out. If you look at the clinical outcomes, all-cause mortality, the cardiac mortality, and the MACE, it was more worse in patients with SMRFs as compared to patients who are SMRF+. So the point was that this is contrary to previous reports for Sweetheart and Concord registries, where in fact it was the opposite for STEMI. Why non-STEMI is probably better? Because non-STEMI actually has a lower in-hospital mortality than STEMI. That is difficult in identifying the underlying etiology. Based on registry data, for example, Minoca wasn't actually very clearly sort of excluded or not very well identified in the study. Patients with Minoca have lower mortality than obstructive CAD, we know that, and milder subclinical SMRFs in these patients maybe could have accounted for better outcomes as compared to patients with STEMI, as was seen in the Sweetheart study. If we look at the disparities of care in smurfless patients, because they don't have any standard risk factors, probably there is a lot of inertia on the part of both patients and physicians. Excuse me. For aggressive risk reduction. So these patients would probably have higher age of presentation. They would have poorer EF. There could be, more incidence of atherosclerosis, and the patients would have lesser incidence of prescriptions for statins, for ACRB, because they don't have the standard risk factors like hypertension, dyslipidemia, so on and so forth. The mortalities are lesser, whether it's in hospital, MACE, or whether it is out hospital as such. Next slide. Closing remark-wise, ACS in patients without SMRFs, a unique group of patients reported in medical literature, not uncommon in cardiology practice. Most data reported from the registries, not positive studies. Up to 25% patients with ACS may present without SMRFs, proportion increasing gradually. Clinical characteristics not very different from patients with SMRFs and practically difficult to identify due to lack of risk factors. Underdiagnosis is likely. Lack of risk factors may result in suboptimal medical therapy and poor outcomes reported in STEMI as compared to non-STEMI. Next. The take-home message from this presentation today would be that clinical risk scoring based on SMRFs are not really adequate. Improved risk score models include genetic, metabolic, inflammatory, and imaging biomarkers of subclinical cardiovascular disease, which is actually necessary when we look at patients who present to us with the standard risk factors that are there. I thank you for a very patient listening, and now I open the session for question and answers. Thank you.
Thank you, Dr. Sunil Thanvil, for your very informative and very interesting presentation on acute coronary syndrome with asthma. And I'm really, I don't know, I mean, I have a little knowledge about the smartless people in acute coronary syndrome, as I mentioned in my introductory talk. And I am a bit surprised to see that it accounts for about nearly 25% of the STEMI and acute coronary syndrome, so quite a high number of people. And these are based on the trials and the observation study. I want to know your personal experience. How often do you see patients without SMA in your clinical practice?
Yeah, so we now have a lot of patients because we are seeing a lot of younger patients now coming to us with acute coronary syndrome, whether it is non-STEMI or STEMI. And so, but naturally, a person who is about 30, 35, when it comes to us with an acute coronary, most of them, they would not be having any of this factor. They may not be hypertensive, they may not be diabetic, would not be having any significant dyslipidemia, maybe could be having insulin resistance, which has not been picked up. The typical metabolic milieu that the South Asians and Southeast Asians tend to have may not have been very overt, laboratory-wise, but clinically, they could be having that typical waist-hip ratio, which could be on the higher side. You could have those typical signs of cardiometabolic syndrome, but not really picked up, or not really very, very well established, so as to account for the ACs as such.
Yeah. Now, we have quite a few questions here. Come on. There are several questions, but I want to confine discussion mainly on the main topic, and then if we can spare time, we'll go to the other questions not related to the main presentation today. And I want to ask again, Professor Sunil, you mentioned that school system. Usually we heavily on the risk factor scoring system to identify the patient with high likelihood of coronary artery disease, either from a risk school or European school system or others, the WHO school system. What would you recommend as which school system should be used in Asian country? Because as far as I know, those school systems were validated only in the in the US, and in the Europe. So what about the school system suitable for us?
I think what works for us, so what works for us, I think, is the presence of cardiometabolic risk factors typically. That is what I've seen works best for Asian population.
Sorry, I don't hear
the cardiometabolic risk factors. So you have the waist-hip ratio, the waist-hip ratio, you have the triglyceride to HDL axis, wherein you have a low HDL, high triglyceride levels, the insulin resistance milieu that could be there. Presence of high hsCRP, I think that is one very significant marker that we should look into when the patient walks into our clinic, who could be likely having an ACS or a CAD. Second thing what we look at is the presence of premature CAD. A premature family history of CAD is again a very significant marker which could tell us that the patient could be having a high risk. Lipoprotein little a, the ApoB100, ApoA1, homocysteine levels. So these are certain risk factors which I believe are more prevalent, more common, more relevant to the Asian population, and probably will give us a better risk factor profiling as compared to standard ACC. Of course, the presence of hypertension, diabetes, smoking definitely will count, but these are additional risk factors we normally look into, especially when you have a young patient coming to us with ACS.
Yeah, I see. Thank you. And next question I would like to ask again is because we usually screen the patient by risk factor, and thereby we can institute some preventive measure by risk factor modification. Because these patients, these smallest patients, they don't have any identifiable risk factor. How can we prevent them? How can we identify them? And how can we prevent them from developing any coronary artery diseases? Could you advise?
So one way could be, so one way could be imaging can be used more freely. We can do the carotid intima media thickness validation in patients who have high risk, say patients whose lipid profile is haywire, those who have premature CAD, those who have cardiometabolic syndrome picture. They could they can undergo a carotid intima media thickness study. If it is on the higher side, and definitely that is one way that we can maybe pick up a very early atherosclerosis that is going on, and thereby we can start preventive strategies so that the event doesn't occur.
Okay.
Second could be a simple ankle breaker index. In patients wherein you have diffuse atherosclerosis, especially peripheral atherosclerosis, ABI which is less than 1 or less than 0.9 could signal presence of excessive atherosclerosis in the body. And event or no event, these patients would require higher and more intensive therapy as compared to patients who have a normal ABI, a normal carotid media thickness, and no other evidence of imaging or any other marker for development of atherosclerosis.
Right. Thank you.
And HSCRP again could be something we could pick up. So we can go for a routine lipid profile screening, an A1C, homocysteine, lipoprotein A, ApoB100, ApoA1. If it is possible, we can go for carotid intima thickness. We can go for an ankle breaker screening. And if it is possible, then maybe we can subject him to a CT coronary, wherein they can pick up the coronary calcium, they can pick up the plaques in the coronary arteries, and that can give us an idea as to what could be the extent of atherosclerosis in his coronary arteries. And that could also guide us for the preventive strategies that the patient should be having.
But I'm still unclear. All these measures you have mentioned, I agree. To which kind of patient the investigation should be done? What kind of person should we do these the investigation? Could you advise?
So I think there'll be 2 or 3 subgroup of patients. One could be patients who have a malignant history of CAD in family, wherein you have patients in whom the parents or the siblings have had a premature coronary artery disease, less than 40 years of age. That could be one subgroup. Second subgroup could be a classical cardiometabolic syndrome, a centrally obese patient, who is having a dyslipidemia, those who are having borderline A1C levels, those who are having high TG, low HDL. So these are all patients wherein I would rather screen them and try to find out at what level of risk they could be to try and prevent an ongoing a future event. Third category could, of course, be a patient who have come to us without any standard risk factors, right? They have come to us with an event. And when we work them up, non-hypertensive, non-diabetic, non-smoker, these are the patients wherein I would subject them to these studies to see as to what is the extent of atherosclerosis, if there's any other risk factor that we're missing out, and what could be the risk factor regulation we need to do so as to prevent any future progression.
Right, thank you. And another question, another request is that because the nature of the audience is heterogeneous, it is diverse with general practitioner, majority type, and some are cardiologists, some are postgraduate students. But for the sake of the general audience, to briefly briefly discuss about the guideline directed medical therapy, because you have in one of the slides mentioned that GDML, they can be effective in those patients with acute coronary syndrome without any SMART. So could you just briefly mention for the sake of general population audience?
What we're talking now about?
What are
So what you're talking?
What are the guideline-directed medical therapies? Just briefly.
Yeah. So now what I'll be talking about is patients who present to us with acute coronary STEMI, say interval MI. For those patients, when the patient comes to the emergency room, they have to be loaded immediately with antiplatelet agents. They could be clopidogrel, 600 to 9 milligram, aspirin, and statin, wherein atorvastatin 80 milligram is the standard recommendation for patients presenting with acute coronary syndromes. In my practice, we have now moved on to ticagrelor, so wherein we now give 2 tablets of ticagrelor along with 75 aspirin, along with 80 milligram atorvastatin as loading dose. There are papers which also say that addition of trimetazidine in loading does help in preventing cardiac remodeling and may be helpful, but that is still, there's no strict recommendation to the fact, but these 3 medications definitely should be there. When the patient has undergone a PCI or post-MI, when the patient has been treated, the standard of care should include a beta blocker, should include dual antiplatelet therapy in the form of aspirin, along with either clopidogrel or prasugrel or ticagrelor, depending on the clinical condition and the choice of therapy of the interventionalist. Prasugrel is not a molecule which can be used in patients who undergo medical therapy. Prasugrel today is indicated only and only in patients who undergo PCI or angioplasty. It cannot be given to patients who have not undergone angioplasty as such. So it's a cath lab molecule. Otherwise, clopidogrel, ticagrelor can be given to patients whether they are undergoing medical therapy, bypass surgery, or angioplasty across the board. Not a problem. So beta blockers, part that we tend to miss out. Patients who have an event are supposed to be at high risk, and therefore they should require extensive statin therapy. So we begin with 80 milligram of statin, and at least for 3 to 6 months. The idea is not to control lipid profile. The idea is to pacify the plaques, because the event rates are higher in the first week than the first month, and the first year, and the next 3 to 5 years. This is the window wherein you can have maximum number of repeat events. So to pacify the plaques that are there, it is very important to give high dose of statins, and therefore the concept of giving high dose of statins for all patients coming to the acute coronary syndrome. Following, say, 3 to 6 months, if the patient is able to tolerate it, then definitely we can look at the lipid profile, look at the LDL levels, and then target the LDL levels to the risk that the patient is at. If the patient is at high risk, the LDL levels have to be 70 or less than that. So statin therapy has to be regulated according to the LDL levels. In India now, the Indian guidelines say that patients at very high risk, meaning those who have 3 or more risk factors, premature CAD, multivessel disease, polyvascular disease, as in the patient has a stroke, has an MI, or has a peripheral vascular disease, the LDL level has to be less than 55. So it is going to be very aggressive. So the statin therapy has to be tailored according to the LDL levels. DAPT, beta blockers, ACE inhibitors and ARBs should be given to all patients, especially with antiviral MIs, to prevent remodeling. Nitrates can be given to patients, those who have LV dysfunction or those who remain symptomatic despite therapy. The MRAs, for example, eplerenone or spironolactone, can be given to patients with LV dysfunction. There is a doubtful role of ARNI now. There are papers which say that addition of ARNI, sacubitril valsartan, can benefit in patients, especially with large MIs, poor LVs, they've given early on. So these are all therapies that have to be there. And I'm not talking about patients for diabetic. Of course, diabetic patients should receive proper anti-diabetic care. SGLT2 inhibitors should be there. GLP-1 receptor antagonists should be there. So these are all therapies that have to be there on board. So by and large, beta blockers, DAPT, statins, ACE/ARBs or ARNIs, SGLT2 inhibitors, and the patients, if they remain symptomatic, maybe nitrates can be added to this group of patients. Trimetazidine has been shown to be a metabolic modulator, has been shown to reduce event rates, can be added to this group of patients to improve several outcomes. So in short, this is what is the guided therapy that the patient of all ACS patient should receive.
Thank you, Dr. Professor Sunil, for your very informative answers. And there are some questions on the chat box, because our audience are very happy to have you on the screen. Why we are having access to the renowned cardiologists. They have asked some questions which may or may not be related to our main topic of today. I hope you don't mind to answer them. So can I go on with the questions?
Yeah. Please, yes.
Yes, first question is that what's your advice on patient presenting with atypical symptoms like angina equivalent, like sweating, dyspepsia, dyspnea? How can we know it is presenting acute coronary syndrome with atypical or just gastritis? This is the question.
Yeah. So I think when you talk about the definition of acute MI, there are 5 things that we need to look into. First, of course, the clinical signs and symptoms that the patient is having. If the patient is having chest pain, which is typical for angina, with perspiration, diaphoresis, then definitely we can think about the acute MI. But as you said, the patient not having typical symptoms, just having some mild gastritis, and they get some discomfort, some sweating, not very sure, I would suggest look at the ECG, right? First thing is get an ECG done. If the ECG is showing a hint of ST elevation or depression, probably we're dealing with acute coronary. The patient has to be admitted and it's under observation. Repeat the ECG over a period of 30 minutes, see if there's any progression. If you have an echo machine at hand, put an echo probe, because echo will show volumetric abnormality much earlier as compared to excessive elevations occurring on ECG. Right? The ischemia will be very apparent on echo. So if you have an echo machine, put an echo probe that will show you volumetric abnormality. Otherwise, ECG, go for biomarker analysis. We'll do a tropi. If the tropi is elevated, you're probably dealing with acute coronary. If it is normal, the ECGs are non-progressive, non-specific over a period of the next couple of hours, they show no significant elevation depression. The tropis remain stable. Probably we are dealing with just a simple non-cardiac chest pain or gastritis or anxiety or something of that sort. In my ER, this is what we do. We look at the clinical criteria, we look at the ECG, we look at the echo, we do a tropi, and if still in doubt, we take the patient to an angio and sort it out.
Thank you. Your answer is very pragmatic, very practical in the daily life, and I hope that the person who has asked the question might be will be justified with your answer. And this question is, could you advise on the introduction of statin to hypothyroid patient who has already started to have levothyroxine to prevent acute coronary syndrome? So hypothyroid patient who is already on levothyroxine, how to introduce statin? That is the question.
Yeah, so I think the guidelines that are, the recommendations that are out there for acute coronary syndromes do not specifically mention anything about the thyroid status of the patient as such. They simply say the patient is high risk, the patient has to be in high dose statins, the patient is in intermediate risk, the patient has to be intermediate dose statins, and if the patient is low risk, then maybe low intensity statin is what is warranted. However, if you are worried about the overall the metabolic milieu of the patient because of statins, maybe you can just keep on following up the patient. The patient has infarcted, ACS, he has to be on high intensity statin, whatever his thyroid status is. It goes without saying. If you're worried, just follow him up with his thyroid status and have a close look at that, the liver functions and the thyroid function. I think more often than not, you will not have any issues, any problems. So far, we have not faced any problems in this group of patients.
Yeah, thank you. Thank you for that answer also. Another question where here, trimetazidine, I think also in India, it is very commonly used. Although there is some, difference of opinion between cardiologists and the endocrinologists and the generalists. Yeah, we are very in the habit, very commonly used trimetazidine. The question is concerned with the trimetazidine. What is the role of trimetazidine in angina? How many duration to get onset of benefits? That's a question.
Yeah, so as I mentioned in my previous discussion also, the trimethazine can be used both as a loading molecule, where there are studies which have shown benefit in patients who have been loaded with trimethazine to begin with. And it has also been found to be useful in patients having effort angina, stable effort angina, or chronic coronary syndrome, as we call it now, CCS. The angina index has improved in this group of patients. When they looked at the walk test, the 6-minute walk test had actually improved in patients who took trimethazine. And overall, patients' requirement of angiogenesis went down when the patients were on trimethazine. Now, do we prescribe it to all patients? No, we don't, to be very honest. Where do we prescribe trimethazine over here? We prescribe in patients where they have diffuse atherosclerosis, polyvascular disease, multiple stents, a patient with chronic coronary syndromes remaining symptomatic despite adequate optimal therapy. So beta blockers come first, CCBs come second, nitrates come third, and then we have trimethazine. We also have ranolazine. We also have nicorandil. We added benefits if we are looking for angina control in our group of patients. The duration of benefit, when it commences, it is very difficult to say because unlike nitrate, which shows immediate benefit when the patient takes it sublingually, trimethazine doesn't work that way. It works at a very molecular level. So the benefit, I dare say, would happen at least a few weeks to 4 weeks, at least it takes for the clinical benefit to show itself. And but it is debatable because at 4 weeks, as it is, all the medical therapies would have taken effect, and whether it is just an added benefit or whether it is a limited benefit, it's very difficult. But in a complex group of patients, we do try trimethazine and we have found beneficial effect when it is added to this group of patients.
Yeah, thank you. I have my personal experience with trimethazine. It takes at least 1 week to get effective when I use it, when I got a acute coronary syndrome. So at least a few days, more than weeks, it takes to be effective. So it's not, as you have mentioned, it's not like nitrates. So it is not you won't get the relief of angina immediately because the mechanism of action is different. But when you say loaded with trimethazine, how much of those do you mean? Because here in this, we have a modified release 35 milligram, usually twice a day, which means 75 milligram per day. But recently, there's an introduction of OD dose, once a day dose, 80 milligram. But I found in the literature, 70 milligram, some trials, 70 milligram. Some trial even use the 140 milligram. So what is your usual dosage when you say loaded? How much do you use?
So we normally load with 35 milligram, 2 tablets, 70 milligrams, that is, and 80 milligram OD dosing. See, basically it is an extended release tablet. So when it comes to loading, it doesn't really work. We need a short acting tablet when we're talking about loading.
All
so
right.
35 milligrams, that's 2 tablets to be given stat as a loading does help. And the OD tablet can be given in patients who are already on trimethazine to reduce the pill burden. And also it is more economical than giving 2 tablets of trimethazine separately. So it has both budget benefit also, and it reduces the pill burden. So that is where the OD formulation comes into play. As far as the dose is concerned, here we have availability of 35 and 80 milligram. I have no personal experience of using 140 milligram, but you're correct. The studies have shown 140 milligram may be also beneficial. But as I said, this works at a very molecular level. It's very difficult to comprehend clinically, as to independently how to show the benefit of trimethazine. It's very difficult because these patients have multiple drugs, beta blockers, statins, DAPTs, nitrates, CCBs. So how to attribute the benefit to this particular dose, it becomes very difficult. But we have seen the patients on optimal doses and you have trimethazine, yes, they do show benefit, even with 70 milligram, even with 80 milligrams. So I think for our population, that dose should suffice.
Yes, thank you. And one more question is an interesting question. What is the role of statin in rheumatological diseases like rheumatoid arthritis, SLE, where hydroxychloroquine has a role in the reducing of the CVD risk to prevent primary CVS event? How about the secondary prevention? So can you answer all that questions?
Though I'm not an expert in rheumatology, but again, as I said, because statins are considered to be one of the molecules for primary prevention, and patients, those who have rheumatological disorders, are always at a higher risk of acute coronaries because they have inflammatory vasculature. They have inflamed vasculature as such, especially those with vasculitis. So probably these patients should be at least on intermediate to high dose of statins to begin with. And I would definitely monitor their HSCRP levels, their LDL levels, to see at what optimal level of statin the patient should be on. That is how I would rather monitor these patients than give a very blanket or very blind dose of statin, because these are very complex patients. They would have muscular involvements too, and additional statin might worsen few of those muscular symptoms. So we don't want to do that. So unless and until it's really indicated, and unless and until it is really needed, a particular dose, a high dose, or intermediate dose, the best way is to monitor by doing the lipid profiles, LDL specifically, and the HSCRP levels.
Yeah, fair enough. Thank you. And another question is highly specialized. I think the person must be a cardiologist. I mean, treatment of type 1 MI, most of us know. But in type 2 MI, the rule of CAT-LAB, what is the CAT-LAB, rule of CAT-LAB in the type 2 MI? So I'm not aware of MI, type 1 and type 2. What is the type 1 and type 2 MI? For me, I don't know. I have no idea. Could you explain to us?
So type 1 MI, the regular MIs that we see, that is because of the atherosclerotic plaque ruptures that come to us. Sorry. And type 2 MIs are basically because of spontaneous thrombus formations that occur. Type 3 are because of procedures, both CABG and PCI. But that is how the whole classification has come out to be. But whatever the type of MI, whatever the cause of MI, I think cath labs are the best solution to all these problems, because time is always important, and the best therapy that can be given to a blocked artery is to treat it, whether it is because of plaque rupture, whether it is because of thrombosis, whether it is because of a stenosis, whatever the reason be. The point.
You are muted.
Yeah, the earlier we try to address this issue, the better. So for me, any MI coming to me goes to the cath lab straight away. I don't really differentiate between MIs and decide whether this MI goes to cath lab. Then depending on what the cath shows, what the angiographic picture shows.
Yes. And also the person proceed to ask what is the role of dual platelet therapy and the role of statins pre and post events. So could you also shed light on that questions?
Sorry, I didn't get the question. Could you please repeat it?
Dual platelet therapy in this type of MI.
Yeah, so I think, again, as I said, that because ultimately we're talking about thrombus and we're talking about the vasculature, we're talking about the plaques, both are equally important. I would not hesitate in adding DAPT and statin across all the groups, even if it is a post-PCI MI, whether it's a post-CABG MI also, these patients would be on DAPT with statin. So whatever type of MI, whatever characteristic of MI, the patients should be on DAPT and statin unless they're actually contraindicated.
Okay. And one more question is that what is the treatment of non-obstructive coronary artery disease?
Yeah, so that is a very interesting subject in altogether. The MINOCA, the INOCA, these are all various paradigms that are out there which are less understood. But it probably occurs because of microvascular sludging, endothelial dysfunction, spontaneous recanalization, spontaneous coronary dissections. These are the probably likely etiologies that have come into picture come into play as etiology in the MINOCA sort of a picture. Therapy would again depend on the angiographic picture, the extent of LV dysfunction that the patient is having, and the underlying lesion. If the patient is young, has a spontaneous recanalization of the artery, then I would still go for plaque stabilization therapy as with DAPT statin. I will look at the echo. If the LV function is normal, probably ACRB I may not continue for long, but at least for the first 4 to 6 months, I will still keep the patient ACRB. Beta blockers will have to be there to prevent shear stress and a further event. So in short, that would be what we'll be looking at. But we may not continue with DAPT high-dose statins for life as compared to patients who are stented, as patients who have stenotic lesions, as patients who have underlying obstructive CAD. So although these patients don't have an obstructive vision, but we should not take them lightly because they do have an event, right? So that plaque preservation has to be there. So at least a single antiplatelet therapy with statins should be there on board lifelong for this group of patients, and beta blocker probably. Yes.
And one of the audience want to know your experience with the Tint. Is it effective? Yeah.
Yes, absolutely. It is very effective in places where we don't have a cath lab and the patient cannot reach a cath lab enabled PCI center the next an hour or so. We do thrombolize patients in India, and tenecteplase definitely works very well, and it's one of the preferred agents for thrombolysis.
Yeah, thank you. One more interesting question related to the rheumatology. What is the role of statins and DAB, dural antiplasia therapy, in vasculitis-induced MI of rheumatology diseases? Is there any role of cath lab, any role of steroids? Could you elaborate on that?
So steroids are not for MI as such, but for vasculitis, I think, yes, definitely steroids will have to be there because that is the inciting event. Patient will have to be on steroid on DAPT and statins because there has been an event. There is a plaque which needs passivation, and to prevent a repeat event, these patients will have to be on therapy to pacify these plaques. So definitely the patients will have to. But as I said earlier, the statin therapy would depend totally on the number of lesions, the amount of atherosclerosis, the level of hsCRP, the level of LDL. But initially, post-MI, I would treat them just like any other acute coronary syndrome. I will not hesitate.
Right, thank you. For the interest of time, it's already here, 2:10. So I would just allow one question, which is, how would you manage a patient with asthma as well as mild chronic congestive heart failure and stable angina? What kind of drug would you use there? So asthma, chronic heart failure, congestive heart failure, and stable angina. So what would you suggest to use?
So I think the probably thought process of this question is whether to use beta blockers in this group of patients or not. I think that is what the thought is. If you're using a selective beta blocker, like say a bisoprolol or a carvedilol, or even metoprolol for that matter, they don't really worsen the asthma in this group of patients. But the older generation drugs like atenolol, propranolol, they are known to definitely induce asthma and worsen the what you call as the spasmodic events. But otherwise, carvedilol, bisoprolol, metoprolol also, nebivolol, they are all very safe beta blockers that can be used in patients who are asthmatic. Again, ACRB should be used, diuretics can be used, aldactone should be used, SGLT inhibitors should be used. So I think except beta blockers, all the therapy remains same. There is nothing really different, except for the choice of beta blocker, where in asthmatic patients, we may try to use more selective beta blockers as compared to less selective ones.
Yeah, thank you. Thank you very much for your very informative answers. So, because we are overshooting 10 minutes to the allotted time, I'm afraid we have to conclude the session. And actually, we have a very fruitful section, academic section, very kindly contributed to us by Professor Sunil Thanvil from Zydus Hospital, Ahmedabad, India, who had talked about the acute coronary syndrome in patients with asthma. So we have learned a lot from you, and thank you very much, Dr. Sunil, for your very informative and very precise and very informative, very useful information on the subject. And I hope we can meet personally some other time in future And you can visit us to give us more, to share with you more vast experience more in the future time. So I will hand back the floor back to the Master of Ceremony. Shisha.
Thank you, Siaji. Thank you so much, Siaji, and thank you so much, Dr. Thanvi. I believe this would have been one of the most interesting deliberations in a long time that our attendees would have attended. And that is very eminent from the fact that we still have significantly large number of audience being present as we even are approaching towards the end of our program. So Siaji, with your permission, as you are aware that the anchor product for the today's event is Zyrova, I would briefly like to present some slides with regards to Zyrova, which is the rosuvastatin with difference. So may I, Siaji, please? So Alongo Minglaba, Chano Name Sheshadri Kobare. So and here I'm presenting Zyrova, which is rosuvastatin 5, 10, and 20 milligram. Zyrova offers more. Zyrova is doctors' trusted rosuvastatin in more than 10 countries. I will skip this video and would come to the benefits that Zyrova offers with the DC technology, that is direct compression technology. With the use of direct compression technology, Zyrova offers better stability. As you can see, each and every batch that we produce for Zyrova has been found to have consistent stability throughout the shelf life of 24 months. So Zyrova, with the use of direct compression technology, brings the benefit of consistent stability. Also, with Zyrova, we use cross-povidone. Cross-povidone is enables the faster disintegration, and it ensures that as soon as the patient takes the tablet is disintegrated at a faster pace. And you can see throughout the shelf life of 24 months, the disintegration of Zyrova has been more than 90%. So Zyrova offers more through direct compression technology, because direct compression technology ensures that each and every tablet has the same friability, same level of disintegration, and is stable throughout the process. Also, the direct compression technology ensures that there is no risk of contamination, and it has been seen that any microorganisms, the very deadly microorganisms such as Escherichia coli, Salmonella, etc., has been found completely absent. So Zyrova offers more safety from microbial contamination. Zyrova offers more stability through direct compression technology, and Zyrova offers faster disintegration through the use of cross-povidone. So would request our attendees and all the doctors to please consider using Zyrova for initial therapy of dyslipidemia, Zyrova 5, for primary prevention in patients at high and intermediate CV risk, our Zyrova 10, and for secondary prevention of CVD, our Zyrova 20 milligram. Thank you so much for your time and attention. I would now request Dr. Neshwe to please convey the vote of thanks to all the attendees today.
Thank you, Mr. Shishadri. Very good day to you all. I sincerely thank to Professor Zydus-Alidac for chairing the session, and Professor Dr. Sunil Thanvil from India for sparing your valuable time and sharing your knowledge, sir. I sincerely thank and appreciate to our commercial excellence team also. Success of the program is from the participation of the doctors. So I would like to take the immense pleasure and thank all the participants and doctors across the globe. Thank you all for your kind support for Zydus. Thank you very much once again, and see you all in our next program. Good day to you all. Thank you.